And I do know I am the thing that's stopping you from getting to lunch. Thank you very much for being in the room. It's been a great session, a long session though, so I'll try and be motivating and keep you awake a little. The COMPARE trial has a range of a large group of people working in it, and I thank my co-authors who are listed on the slide. But there's a number of people in the room that have probably been working in COMPARE. Thank you so much for all you're doing, and I'm hoping that this talk might encourage a few more recruits, both in terms of participants and staff. So we've heard over the last day and a half that the Brady-Cochrane review, systematic review, has underpinned a lot of the rationale for why we're doing research at the stage we're doing it. And that review headline finding was that there's improved functional communication, reading, writing and expressive language immediately after aphasia intervention, but interestingly not at follow-up. And from that data set there was an indication that functional communication is significantly better following high intensity, high dose or long duration of intervention. But that finding was confounded by a higher dropout rate, particularly from the acute patients in the studies. So the review ended with a plea, and the plea was for quality trials that compare different treatments, so head-to-head, the dose and schedules, and importantly look at follow-up. Since that review, a study came out in the Lancet in 2017 by Katharina Brittenstein and colleagues from Germany, and it's an interesting addition to the focus of evidence in chronic aphasia. So in that study they asked, does 3 weeks of intensive speech and language therapy under routine clinical conditions improve verbal communication in daily life situations in people with chronic aphasia? And that study had 156 people, which they randomised into 2 arms, an active treatment arm and a delayed control arm. The treatment comprised 30 hours over 3 weeks, so an intensive dose. And it was a linguistic and pragmatic based intervention, mostly an individualised therapy, but some group therapy. And they looked at a functional communication outcome measure. They also looked at mood, quality of life, and partners' views of any improvement. And there was a collective sigh of relief in the world when this study result came out, because it showed a medium effect size on the primary outcome measure, the UNELT, and that was shown to be stable at 6 months, although as Maya pointed out earlier today, most of the people in that study had some additional period intervention in the follow-up period. And importantly, 107 or 69% of those participants showed improvement. So, you know, often with these big studies we see the mean change and average change, and we don't know how many of the individuals actually got better from the treatment. And as clinicians, that's what we need to know if we're going to recommend treatments to people. They also showed significant change on quality of life and partner view measures. And interestingly, initial aphasia severity was the only predictor of outcome in that study. And they had a subgroup of people that got an additional boost of this treatment, and they continued to show additional improvement, which was an interesting finding. So when we started to approach this work of what needed to be compared on the back of the Brady plea, we looked at constraint as the obvious place to begin. Constraint treatments have had a lot of research activity since 2001, when Professor Pulver-Muller first explained them to us. And you would know that they're based on constraint-induced movement therapy ideas, that they're based on principles of neuroplasticity, largely derived from animal models. And the prime sort of thrust in this is that you're trying to minimise any learned non-use that's happening because of the aphasia by encouraging and constraining tasks to talking. So the aim of these treatments is speech production and improved verbal communication, and intensive production of speech. Socially relevant group interactions are used, and the cueing focuses on spoken repetition and reading of target words and phrases in many of the studies. And sometimes there's barriers that are placed between the interactants to discourage non-verbal communication. Now, a sort of opposite to this type of therapy is one that we talked about and published in 2013, the multi-modal aphasia therapy. And it's also based on principles of neuroplasticity, but with an additional focus on the idea that we are trying to engage a distributed neurological system that underpins communication. And in this way, we keep with the intensive production of speech, socially relevant interaction, but this time we're using multimodal cues to get to the talking. So we purposely use gesture, writing, reading and drawing as a way to get to talking. So the aim is still speech production and verbal communication, but of course multimodal communication is practiced by default in this protocol. Now, what's the evidence that leads up to the way we've set up our trials? So if we look at the Brady paper, we can see that there were 5 trials that compared constraint to other therapies. And the sort of headline news from those reviews were that there was no significant difference either in functional communication or aphasia severity from those trials. And a more recent systematic review of randomised controlled trials from the Zhang group included 8 randomised controlled trials, and they did 3 main comparisons. And the headline news from those is that both in chronic and acute phase, there was non-significant differences in terms of SIAT and an unconstrained lower intensity dose. No significant difference in the primary outcomes when the dose was consistent between a constraint and a non-constraint treatment. And the only really sort of flash of something that might suggest that SIAT or ILAT is superior here is this one, the most recent one from Stahl group in Germany, which shows significantly better result for ILAT immediately post-intervention compared to a confrontation naming treatment done at the same dose. More recently, John Pearce and his group of supervisors, including me, looked at literature beyond randomised controlled trials in this topic. And just to sort of quickly summarise, what we've got here is a graph that shows the types of treatments, so constraint and combined and gesture and writing. And anything to the right is saying that there's been some improvements. And what we see here is that there's certainly no obvious advantage for constraint over the other treatment types from this small amount of single subject work. There's a lot of caveats in how we interpret this information, but the signal for constraint is not blaring out at us as something we should be only focusing on. So the John's systematic review conclusions were that there was encouraging but low moderate quality evidence for the efficacy of constraint, but most of this information came from small RCTs and non-randomised controlled trials, and very few compared direct equivalents in non-constraint controls. And that the multimodal evidence was predominantly single case experimental designs and non-randomised controls, and that there was insufficient evidence to demonstrate clear superiority of one over the other, and minimal focus on measures that we might care about. So this led us to engage in the COMPARE trial, which is running currently. It compares constraint-induced aphasia therapy and multimodal aphasia therapy. And our prime aim is to look at the comparative efficacies of those in comparison to usual care. But we're also particularly interested in predictors of treatment response and the relative costs and benefits in terms of health economics for these treatments. We've hypothesised that they'll both help to make aphasia severity less immediately and post-intervention at 12 weeks, and that they'll impact positively on measures that we care about, such as accuracy and efficiency of connected speech, functional communication and quality of life. And we've gone out on a limb and used a very small amount of evidence to suggest that there might be a differential effect according to aphasia severity, such that MMAT might be more effective for people with severe and mild aphasia, and SIAT might be more effective for moderate aphasia due to different underlying mechanisms in these treatments. So basically it compares a 3-arm randomised controlled trial. We're aiming to get 216 people into this study, so 72 in each arm. And the treatment is 30 hours delivered as 3 hours per day for 2 weeks. And 3 people work together in a small group with a therapist, and those groups are randomised, stratified on aphasia severity. All the assessments are blinded, the primary outcomes immediately post, but we have the 12-week follow-up. And we've sneakily included a sub-study into this trial where we get a sneak look at what happens when we do a distributed dose of these interventions, so at 30 hours over 5 weeks, which many clinicians tell us might be something, if we get some strong evidence from this trial, they could implement in clinical world. A range of outcome measures, and I won't spend too much time going through them, but the Western Aphasia Battery Aphasia Quotient is our primary outcome. But you might be relieved to see that we've got measures of functional communication, multi-modal communication, discourse, and that's importantly between a significant other and the participant, quality of life, and as I mentioned, the health economic piece. And importantly, we have a range of predictor measures, which we hope, if there's strong signals in this data, will give us some indication about why does it work for whom, what works for whom, which when we're trying to do clinical reasoning and we're trying to choose a treatment, that's where we start, right? So we hope that there's some signal in here. Our timelines, we hope to be done by the end of next year for data collection, but we need as many of you in the room as possible that can help us get participants into this trial. So we're recruiting directly from community sources through social media and, for example, community aphasia groups, but we have also a host of magnificently supportive healthcare networks and clinicians that have helped us get ethics through and trawling through their past patients to see if these people could be suitable for this trial. And to finish off, I just want to show you that we've reached 105. I was hoping today I could say 108, which would be the halfway point. There are 2 cohorts ready to be randomised, and we're waiting on a couple of little things, so I can't say that. I wish I could. And you can see that we're trying to get to our 216 by the end of next year. That's where we're operating at the moment. FNQ, we hope you're going to come on board. People from Townsville, I'd love to speak to you. And Sunshine Coast, we're screening at the moment, so if you know some participants, that people with aphasia who might like to participate, let them know about the trial. And we're starting in New Zealand as we speak. So please help us get the word out to people with aphasia about this trial. We really need this evidence, and we can't finish the trial unless we have the 216 participants. Thanks for listening, and enjoy your lunch.
Thanks, Miranda. We will leave it